Ok, il est midi. Bonjour tout le monde et puis bienvenue à ceux qui nous ont rejoints par Zoom. Je m'appelle Walid Abre, je suis président de la commission chargée d'étudier aujourd'hui la titularisation du professeur Philippe Bilinga à la fonction de professeur associé au service de neurochirurgie au département académique et hospitalier des neurosciences cliniques. Donc, le professeur Bilinga, il a 20 minutes pour nous faire une belle présentation sur un sujet qui l'intéresse beaucoup, qui est l'usage de la réalité virtuelle en chirurgie. Alors, le titre de sa présentation est Digital Transition in Neurosurgery. Et je rappelle les gens qui sont par Zoom, qui peuvent poser leurs questions. On pourra les voir par la suite et adresser les questions à tout le monde. Voilà, je laisse la parole.
Merci beaucoup. Alors, on m'a demandé de présenter en anglais, ce que je vais faire, donc je vais directement transiter. Dear Dean, dear Commission members, dear experts, dear colleagues, dear friends, family, it's for me a great pleasure to describe the digital transition and how it is progressing in neurosurgery, and more specifically in the field of intracranial aneurysm disease management. The setting you see here by Bensky actually represents my mindset regarding information technologies in health. Let us take an illustrative example. We have here a middle-aged woman that complains of headaches. Her general practitioner feels uncomfortable and asks for a head imaging. The head imaging shows an intracranial aneurysm. An intracranial aneurysm is an irregularity on an intracerebral vessel. It's a bubble that may grow, may get irregular, and may rupture. So yes, some aneurysms are bombs, but not all aneurysms are bombs. How can we distinguish the safe aneurysm from the dangerous ones? Is it true for a woman that this particular aneurysm is dangerous? Is it applicable to a man? Is it applicable to anyone? What is the best treatment for each patient? This is all about balancing risks and optimizing resources, reducing the burden of the disease on society. A solution to address all those questions and issues is to use information technologies. And information technology is all about data. Data is the encoding in zeros and one a computer can process. And data and information technology, is all about creation of data, storage of data, processing of data, and exchange of data. A decade ago, I had the chance to be involved in designing a digital patient roadmap. And it was very clear from the beginning on that there were essential requirements that needed to be addressed. First of all, experts in the field need to define what are the concepts that underlie a field, what are the common data elements, and then the community has to agree on how to digitalize all those common data elements. And those common data elements are interacting, and it's really important to model the interactions between all those common data elements. And those models, they depend on the purpose we want to use the data for. Therefore, those models will evolve over time, and it's very important to very early think about monitoring services that allow to modify the models across time and follow evolution, and then also to implement feedback loops that allow optimization. And it's one of the main purpose of all those information technology is to optimize different things, and having optimizing mechanisms is essential. When you think about designing an information infrastructure, you also need to know who you're going to address to. And here, regarding health, it's also very important to realize that we actually almost address this information technology tool to everyone. We need to inform citizens. We need to inform patients. The information system ultimately is going to provide decision support and assist care providers. It's also going to provide data to scientists to make new knowledge discovery. It's going to provide data to industry to develop and innovate new devices. And ultimately, it may even give information to decision makers to optimize resources. And all that should facilitate users to comply with data protection rules and good clinical practice. As information technology are highly scalable, it was and it still is recommended to think big and to think global. In Switzerland, there is the initiative Swiss Personalized Health Network, which is precisely working on developing such an infrastructure. The National Institute of Health in the USA, and in the context of intracranial aneurysm, the National Institute of Neurological Disorders and Stroke, funded an international effort to identify and define the common data elements of intracranial aneurysm disease. And under the lead of José Suarez and Locke MacDonald, the group released a set of articles now used as reference. As a legacy of the Aneurysm project that ran from 2006 and 2010 in Europe, involving 26 centers, a model has been proposed that organizes the data elements according to the disease, allowing the definition of patient groups suffering of different forms and stages of the disease. Using classifiers, assess how patients transit from one stage to another according to variable factors, and define outcomes specifically to each disease stage, and ultimately to monitor the disease burden on society and optimize the disease management. The model allowed the design of a structure that stores the data and resulted in the aneurysm data bank, which is currently retrospectively and prospectively populated with data. It is well known in the IT community that you only receive from a computer what you feed him. A computer is just processing data. And if you provide bad data, you're going to have bad results. The other thing is that everybody wants to have great data, but nobody wants to clean the data. And therefore, I really like to thank Antoine Geisbühler and Christian Lovis that very early on in the process made us aware on the issue regarding data collection and data collection quality, and to need to explore solutions to improve the quality of the data obtained from doctors. The following solutions are currently tested. The first solution is to use a decision support tool that will assist the care provider in systematically assessing patients. This decision support tool will immediately deliver to the caregiver a personalized process data addressing precisely the condition of the investigated patient to take decisions. Here, the estimates of aneurysm rupture rates specifically for that patient. We also recommend to involve the patient very early in the data collection. And actually, involve the patient while you assess by using this checklist to explain the disease to the patient and explaining how he is assessed to allow the patient to actually verify that the data which is recorded is actually correct. The fourth solution is actually to publish the filled form and the result of the calculated process in the patient file and make the patient file available to the patient anywhere and anytime. And here again, thank you to Antoine Geisbühler and his team for developing mondossier.ch and currently the CARA service, which in all the Western Switzerland allows patients to access their medical file. This reduces transcription errors, but has no effect on the quality of the patient assessment. Here is a nice study made by Nicolas Maldener in Zurich that precisely measures the agreement among physicians assessing a series of aneurysms. Nicolas sent images from 30 consecutive cases to 10 raters, 5 experts and 5 junior raters. And then he looked at the result. And what you can see here is that there is a relatively good agreement regarding on which side the aneurysm is. But already, if you want to classify aneurysm by location, which is a very important factor, you see that there's some degrees of disagreement. And you see that when assessing the size of the aneurysm, there is some degree of disagreement. But even worse, if you ask people if there is one or multiple aneurysms, you actually see that there is a very strong disagreement because people overlook, and even experts overlook, if there is one aneurysm, they don't see the second or the third one. And regarding the shape assessment, here you have a very strong disagreement. So this motivates the community to develop tools to assist in the assessment of those dimensions. So groups are working on automatic aneurysm detection tools. We are working on that too, but I'm not going to talk about that now. I'm going to talk about the automatic analysis of aneurysm shape. And this was actually one of the main purposes of the ANUX project funded by System X, where we assessed shape as a biomarker of the aneurysm disease. The team worked on automatically extracting the vessels and the aneurysms from the images and automatically assess different size, different dimensions of the aneurysm, and came up with up to 50 different dimensions of aneurysms. And as a team work at the worldwide, we were working with Juan Sebral and Mason University. We were able to prioritize all those dimensions, and by machine learning on 2,129 aneurysms, we were able to generate classifiers which were quite precise, as the best one has a 94% precision in classifying aneurysms that were ruptured or not. Concomitantly, we know that experts claim that they are able to identify aneurysms that will rupture from aneurysms that will not, just from shape. And what we did is we asked those experts to rank 134 aneurysms according to their risk of rupture, or what they say their ugliness. And here we have what we call the perceived irregularity. And on the basis of this data set, we, using machine learning, developed a tool that allows to reproduce this classification done by users. Now, as I said in my second slide, assessing aneurysms need to be put in the context of patient, and we need to address patient's question. One of the very frequent questions we have is there a possibility to identify a population at risk? Yes, patients that have a positive family history for aneurysms have a higher risk of having an aneurysm. And this risk is so high that we actually recommend a screening program with regular imaging. But what about incidental cases? And here, an international effort allowed the collection of information regarding patients and aneurysms that benefited from whole genome scans and healthy volunteers. And by pooling the data of more than 11,000 patients and more than 700,000 healthy volunteers, the team was able to identify 17 loci that were associated with the disease. How to best exploit that discovery is still under investigation. Another relevant exploitation of the data is to create a mechanistic model of the disease that would allow to simulate the evolution of the disease according to variable factors. And this requires a better understanding of the mechanical stress of the blood flow on the vessel wall. It requires also understanding the consequences of defective genes and defective proteins that senses the flow on the surface of the vessel. It also requires that we understand the remodeling and repair mechanisms of the vessel wall and the resulting alteration of the vessel wall structure, and ultimately to identification of new biomarkers of the vessel wall instability. A third topic is to assess the disease burden and the safety of our case selection process. Data was collected on the population basis in Switzerland, with Swiss SOS as a team unifying all the university hospitals in Switzerland. And that team allowed the collection of data that allowed to assess that 900 patients every year suffer an aneurysm rupture, and 200 will die. 22% only of those patients will fully recover. The good news is that, yes, there is a population of stable aneurysms and a population of patients that will never suffer from the aneurysm. And we are able to identify those aneurysms and keep those patients safe. The issue now is to better identify when the aneurysms get unstable and eventually take medical measures to prevent instability, and for those who suffer unstable lesions to provide safer interventions. Regarding interventions, there are currently only two modalities: surgery and endovascular intervention. But there are plenty of devices and a very strong industry with a high rate of innovation. What is lacking is a proper assessment of the treatment efficacy and safety. We actually have to choose between a nail and a screw or a hammer and a screwdriver. There are many case series reporting the benefit of specific devices on carefully selected patients, but no real comparative assessment. The latest meta-analysis published in 2012 reported a rate of procedure poor outcome between 4 and 6% for coiling and clipping. A nationwide Korean study reported a rate of poor outcome of 6% for stenting. There is no single treatment modality that is clearly superior, but there are clearly lesions that are better treated using the proper tool. Currently, decisions are made by pooling the experience of multidisciplinary team. Regarding surgery, how can we improve the safety of our surgical treatments? Well, first, by improving the teaching. And here you see two residents that are not looking in the emptiness. They're looking at a mixed reality representation of the patients we are operating on tomorrow. And they look at the lesion, and under supervision of an instructor, they learn how to better approach the lesion. We also work on standardization of the approaches so that actually we can reproduce our gestures and avoid obstacles and avoid excessive tension on the tissues. We also use information technology to encode the signals and allow to see the function, here the blood vessel flow. And finally, we advocate the use of imaging during the procedures to assess the quality of the procedure right away and correct eventually. So here, intraoperative angiograms in hybrid rooms. And finally, an intervention is just not a surgeon. It's a teamwork. It's a teamwork with an anesthesiologist, with scrub nurse, with electrophysiologist. And here is our new GBOR, our new intraoperative MR suite. And to get people used and trained to work in that environment, we actually have now a 360 environment that allows people to learn where things are and how to behave in this environment. And we have now a virtual reality environment that replicates this facility and allows people to train either alone or as multiple players to work together. And what we see for the future is the ability to avoid having visitors coming in the operating theater, but to offer the possibility to have a virtual presence in the operating room by sitting in a virtual environment or moving in a virtual environment and having access to all the digital data available from the operating theater. This will improve the communication we have with scientists exploring the brain. Now I talked about the acquisition data and the processing of data. I was talking also about optimization. And regarding the dimensions we have to optimize the use of data, we currently optimize according to mortality and eventually morbidity, maybe costs. But we all believe strongly that what is most relevant for the patient is the impact the disease will have on quality of life. And that's where we foresee a very strong collaboration with the lab of Katrina Vack, who is actually working on portable devices to allow the quantification of quality of life. So that's actually the end of my talk now, and I'd like to acknowledge all the people that participate to the work during the last 15 years, and I especially like to thank Nicolas de Tribolet, my mentor, that trusted and constructed a great team in Geneva. I'd like to thank Daniel Rufnat that trusted us too and involved us in the aneurysm project as leader of the data collection exploitation. And finally, last but not least, I really like to thank Carl Schaller for his energy, his motivation, and his ever very strong support that paves the way to success. Thank you very much.